Dear colleagues, this is my pleasure to contribute to this OncoAlert Colloquium and to discuss the recent advances in vaginal and vulvar cancer. This is my disclosure. As you know, vulvar and vaginal cancer are rare diseases. Vulvar cancer accounts for less than 6% of all gynecological cancers. There is an increasing incidence with two peaks. One peak that affects the patients less than 50 to 60 years old, which is related to HPV exposure, and one second peak that is preferentially observed among the older patients in the context of lichen. We have very few prospective trials and a low level of evidence. The level of evidence is still lower for vaginal cancer, that accounts for less than 2% of gynecological cancers, and we have no randomized trial in these patients. For now, the last European guidelines have been published in 2023, and in vulvar cancer, they refine the respective role of surgery in radiotherapy. They highlighted the role of dose escalation for advanced cases, and it was highlighted the paucity of data on systemic treatments that are mainly derived from cervical cancers. The same year, we had the publication of the ESTRO-ESGO-SIOP guidelines for the management of patients with vaginal cancers, highlighting the role of modern radiotherapy and brachytherapy techniques to increase local control and to minimize morbidity. We didn't have in 2025 any prospective study that may change the pattern of care in these patients, but we have an amount of interesting studies, retrospective series or few prospective studies that aimed at still improving the patterns of care in these patients. This prospective study investigated image-guided surgical navigation for inguinal sentinel lymph node procedures in vulvar cancer, and the author demonstrated the potential of image-guided surgical navigation to find the inguinal sentinel lymph node even in the most challenging cases, and they concluded that this procedure could potentially avoid more extensive procedures such as complete inguinofemoral lymph node dissection. Navigation was also helpful for patients with high BMI and deep or small sentinel lymph nodes, and they concluded that this approach was helpful to determine the exact location of sentinel lymph node. Last year, we also had some data that are useful to refine the prognosis of patients with vulvar cancer. And in this systematic review and meta-analysis that was published in 2025, it was shown that TP53 wild-type HPV-negative vulvar squamous cell carcinoma constitutes a group at intermediate risk between the prognosis of patients with TP53 mutated vulvar cancer and those of patients with HPV-positive vulvar cancer, which have the best prognosis. The role of chemotherapy in metastatic patients and the place of multimodal approach in these patients was also investigated in this NCDB database with more than 700 patients treated between 2004 and 2015 and had metastasis at diagnosis. What has been shown is that patients with only lymph node metastasis had a better prognosis than those with other distant metastasis, but also that the added value of multi-agent chemotherapy was limited, with no difference between the multi-agent chemotherapy and single-agent chemotherapy. The author found that among the group of patients with lymph node metastasis only, the combination of chemotherapy and radiotherapy was better than any modality alone in terms of prognosis, highlighting the role of intensive systemic and radiotherapy approaches in these patients. There is an increasing role for immunotherapy in metastatic vulvar cancer patients, but the level of evidence remains very low. However, we had this year a publication of this phase 2 basket trial that tested the addition of pembrolizumab and vorinostat, an inhibitor of histone deacetylase, for a patient with recurrent or metastatic vulvar cancer, and they included a lot of indications, and you can see that there was 17 patients with vulvar or vaginal disease. In this table, you can see the complete response, progressive response, stable disease, and progressive disease rate in the cohort of patients with vulvar or vaginal cancer. You can see that 90% of these patients who had advanced cases had a response to the combination of pembrolizumab and vorinostat, with a duration of response that was quite short, 3 months. And you have on the right the waterfall plot based on the best target lesion reduction in the per protocol population. What is interesting in this study is also that they identified some predictive biomarkers such as the HPV status that was correlated to a better progression-free survival compared to negative HPV status. The tumor mutational burden was also correlated to outcome, which was better in case of high TMB. For advanced cases treated with chemoradiation, we had a phase 2 that is still not published, but presented at the last ASCO meeting with 24 patients with locally advanced vulvar cancer, T2 to T3 not amenable to surgery. They received chemoradiation plus combination of pembrolizumab, and at 6 months, the recurrence-free survival was 70%, overall response rate 75%, and 37% of the patients had a complete response. This study has some limitation. It adds to the rationale of combining immunotherapy in the management of advanced cases, but still there is no validation, and therefore this is only investigational strategy for now. In vaginal cancer, we had a randomized phase 3 trial that was not dedicated to vaginal cancer, but that included some patients with vaginal cancer. They tested the addition of triaptine to cisplatin chemoradiation. This is a ribonucleotide reductase inhibitor, and unfortunately, the study is negative with a hazard ratio for death that includes 1, and a hazard ratio for progression which is also not significant. To conclude, there has not been a practice-changing study in 2025, but we have an amount of data suggesting the possibility to do a better stratification of vulvar cancer based on the molecular patterns, that there is an increasing role of dose escalation in advanced cases and an increasing role for immunotherapy in these patients. We still await additional prospective trials to change the patterns of care in these patients. We hope there will be some coming studies in 2026. We have ongoing trials testing surgery and or radiotherapy modifications, dose escalation, addition of immunotherapy, but we also have in the most advanced situation some prospective phase 1 to phase 2 that may add to the available literature on the best treatment in best systemic treatment in metastatic patients. Thank you very much for your attention.